I'm going to be giving our next lecture, which I hope will feed very nicely into the one that he just completed, which is called Understanding Non-Response and Loss of Response in IBD. Which is it, and when do we change class of therapy? And this is meant to be a very practical talk for the clinicians in the room, and I think it'll lead well into the remainder of our program today. I do have some disclosures, but these slides and my comments are all my own today. So what I'm going to do in the next 20 minutes is really provide you with a framework to approach your patients who are not responding to their initial therapies, what we call primary non-response, and an approach to patients who responded to their initial therapies but now are losing response. Some people call that secondary non-response or loss of response. So I want to remind the audience, because I recognize we have people here from many different levels and experiences, that the reason we treat IBD is because it makes people feel sick. And what we're trying to do when we're treating IBD is to improve quality of life. And it sounds very obvious to make a statement like that from the podium, but the reality is that we sometimes forget what the bigger picture is. And when you understand that, of course, you can also appreciate that the way we treat inflammatory bowel disease is actually directed against what we observe, which is an uncontrolled immune response, an active inflammatory problem. And that's why most of our treatments, of course, are directed against the immune system. We provide immune modification or immune suppression to try to control what we're observing. We unfortunately are not treating the cause of IBD. And because we're not treating the cause of IBD, the natural tendency of this condition after you get it under control is for it to find a new way around that and to start activating itself again. So we really focus on what do we know? We know that these patients have activated inflammatory responses in their gut and sometimes elsewhere, and that causes symptoms that makes their quality of life poor. What we'd love to do is be more thoughtful and understand a bit more about the pathophysiology of the condition, and there's been interest, although not as much progress quite yet, in the concept of microbiota manipulation. That refers to manipulating the microbiome of the gut in order to gain control of the disease. If we think that IBD is being driven by a disturbed microbiome or a dysbiotic condition within the gut, then the concept of trying to shift it back towards a balanced state makes some sense. If we believe in our heart of hearts that IBD may be just a complicated infection, looking to the microbiome and all the organisms that live in the gut makes some sense. However, the treatments with antibiotics, prebiotics, probiotics, fecal transplants, bacterial-derived proteins, and of course diet have yet to demonstrate very striking results. But there are some studies that are worth learning about, and that's one of the reasons why we're excited to hear from Jim Lewis today. And then lastly, of course, we would be remiss if we didn't acknowledge that one of the major treatment strategies for controlling these diseases, especially when they have progressed, is surgery. And we shouldn't leave surgery until everything else has failed. We should be thoughtful about implementing it earlier in our patients' management when we can. So we'll talk more about how to get to that. There are a variety of challenges to managing the patient with inflammatory bowel disease. The first is the problem that we're dealing with more like 50 or 100 different diseases that we lump into Crohn's and colitis. The human body's quite amazing, but it can only express itself in certain ways. So whether this is a problem that's being driven by a known infection like Clostridium difficile or a problem that's being driven by some genetic susceptibility to an environment, it will look similarly the way we see it when we look with our scope, when we look under the microscope, and when we certainly when we ask our patients how they feel. So we have some challenges there in recognizing the vast heterogeneity of IBD, and that's one of the reasons why therapies don't work uniformly. The second problem we have is that despite having great therapies and making tremendous advances in IBD, we still have a large primary non-response rate, either for individual patients or for the therapies and classes of therapies. Even after patients respond, unfortunately, many, if not most, will have some loss of response over time. This is a very big challenge, not just for us to manage, but also because the patient really loses confidence in their ability to control their disease. And it's one of the biggest fears patients have. Am I going to make it to that important social event, or can I even sit through the car ride to work in the morning? So loss of response and the lack of control is a very important issue. And then lastly, we have to acknowledge that both the disease and the patient change over time. Patients grow, they gain weight, they age. There's a variety of changes that occur that we recognize. And the diseases change. They progress, but also the mechanism driving the inflammation changes. If we block one pathway in a patient by choosing, for instance, anti-TNF, only a matter of time before most patients, if they have a more aggressive disease, their body's going to find another pathway around to drive that inflammatory problem. So it is natural for patients to lose response. So the next time you're in clinic with a patient who asks you if they're going to be on the therapy you're recommending for the rest of their life, of course the answer is no, we're going to make more progress before then. But unfortunately also, even if this works now, it may not work very long, and we need to be thoughtful about this. So let's focus now on the patient not responding to therapy, primary non-response. So this can be defined in a variety of ways. If I asked everyone in the room to tell me when they would switch therapies after starting a specific agent, I bet I would get 50 different answers. So I'm going to try to provide a little more uniformity here. First is, it's based on the type of disease and the scenario. If you have a hospitalized patient with severe UC, a number of studies have demonstrated that if you're providing IV steroids, after 3 days of IV steroids, if the patient hasn't responded, they are not going to respond if you continue it for 7 or 14 days. You should be making a decision about another therapy after just 3 days. Now notice, I'm not saying they should be in remission, but they should be feeling better. Another example might be the patient who's got recurrent Crohn's after surgery. Is this somebody who has recurrent Crohn's despite you having them on therapy? Or is this somebody who has recurrent Crohn's because they were on nothing, because they felt well and they didn't want to be on therapy, and you didn't look for a year after they had surgery? And understanding whether or not they're truly not responding to medicine or whether we just waited too long is important. And lastly, and maybe more commonly for people in the room who are more experienced clinicians, when a patient hasn't responded to multiple therapies sequentially, that might be the classic case of primary non-response, the tough patient that we're all struggling with. What do we do with them? And that's when getting second opinions and others is very helpful. So you can break it down further by class of therapy, and I have defined this based on the clinical trials for the most part. If you're providing 5-ASA therapy, make sure you're maximizing oral and rectal delivery before you decide it's not working. Give it 2 to 4 weeks before you assess whether it's doing anything, but certainly they should not be feeling worse. We know that some patients are intolerant to 5-ASA. They should have some improvement by the time 2 to 4 weeks are up. They won't be in remission quite yet in most cases, but it's very important to know that. Steroids in general we use too long, and we have to be thoughtful about how we're putting those into position and try not to provide tapers that are going on longer than necessary. But if a patient's not responding to the steroid preparation you've given them after a week to 2 weeks, move on to something else. Methotrexate, thiopurines, a little slower, although metho may be faster acting than the thiopurines. But in general, people say after 6 weeks, if you haven't noticed any improvement, you might want to be moving along. You probably want to wait a little bit longer if you're still using those agents. And more rapid onset includes our anti-cytokine therapies like the anti-TNF and anti-IL-12/23 and the anti-integrin therapies, where we're providing them subcutaneously or intravenously, and we want to see these patients responding. In general, after 2 loading doses, we'd like to think that they're improving. By the 3rd, they should be well on their way to achieving remission. Giving these therapies for months when there's been no response is not a practical approach and is just prolonging the patient's suffering. So those are some definitions for you to think about for primary non-response. Now, the approach to the patient is for you to be asking yourself, is this a mechanism failure? In other words, is the treatment strategy I've chosen not working for some reason, or is it a dose failure? So could this be a concomitant infection you're not treating? Is there some other biological mechanism that we don't quite understand that's just not going to work here? Or, unfortunately, and as Mark introduced, is this not inflammation? Are we treating scar tissue with anti-inflammatory therapy? I always have to excuse the expression, but the way I say it to patients is it's like beating a dead horse. You can give more and more anti-inflammatory therapy, but if you're treating fibrosis, you're not going to get progress or improvement. Or is this a dose failure? Most often it's because we're underdosing, and that is a criticism of us, but it can also be a criticism of payers and the FDA, who have not appropriately approved, labeled, and acknowledged that there is a dose range that is needed for many patients, especially with monoclonal antibodies. And believe it or not, sometimes we're overdosing. You might be surprised to recall that in a study where they compared 2.4 grams of mesalamine to 4.8 grams of mesalamine, patients with mild ulcerative colitis actually had more symptoms when they got the 4.8 grams because of side effects than they did from their original mild colitis. So we have to be thoughtful, and we still need to be clinicians here. And lastly, of course, is this big issue of exposure, and we're going to learn more about that from Adam when he talks to us about therapeutic drug monitoring. But is it true that the drug we're giving in terms of its dose is actually getting to what we need in terms of the exposure for the patient's physiologic problem? And that's a challenge that we face, and that's one that we're trying to get a better control of. So how do you approach these patients? Thoughtfully. Rule out strictures and infection. Use objective measures of disease activity. Don't rely too heavily on their symptoms, although you know your patients and they know their bodies. Consider drug intolerance. So if you think 5-ASA may actually be worsening their condition, stop it. Within a few days, you're going to know. I had a patient I just saw for a second opinion recently who had been on 5-ASA through all these other drugs, escalating up the biologic ladder, and in fact, she was mesalamine intolerant, and that was what was driving her disease for 6 years. Confirm adherence. Is the patient taking what you've prescribed, and can they take it? Can they even afford it? And of course, that's a huge issue these days. And then a last pearl is consider switching from sub-Q to IV if you're using anti-TNF. We know that there are convenience factors related to choosing a self-injectable agent, but there may be benefit in going to the IV when there's a primary non-response. So just to state that in a different way, if you've started with adalimumab for your patient with Crohn's and after loading they're not improved at all and you don't feel like they're responding, don't give up on the mechanism. Consider using IV infliximab based on weight-based and its different delivery system. You may actually capture some patients. Conversely, if you start with IV infliximab and they're a primary non-responder, switching to the subcutaneous therapy is not recommended. The mechanism was the same, and the delivery is going to be a little bit less, and it's not worth trying. So that's my recommendation there. There are a variety of factors that affect the pharmacokinetics of monoclonal antibodies. The first one, and we talk about it all the time, but to be honest with you, it's not a majority, but it does happen, of course, is the presence of anti-drug antibodies. The second is the concomitant use of immunosuppressants. So if you have the immunosuppressant on board, it decreases the clearance. In other words, it increases the level of the drug and it prevents antibody formation. The third is a high baseline TNF level. This is not the drug. This is the actual substrate, the TNF itself. We don't measure that in clinical practice, but there are some good studies going on now that are both looking at serum and tissue TNF as a predictor of response to anti-TNF. A very important one, and the one that Dr. Kersner taught me about, was low albumin. Somebody with a low albumin is going to clear drug more rapidly, and they're not going to do well. So the patient who's lost a lot of weight related to their disease, or who's just quite ill, or who's losing protein in their stool, also is going to be less likely to respond to monoclonal antibody therapy, which should make sense to you. They're sicker, but they also are wasting protein, and the monoclonal antibodies are proteins. So they're basically pooping out their medicine right into the toilet. And I often say to patients, it's like filling a bathtub when the drain's open. You can't quite get where you need to go. And then having a high baseline CRP as a marker of inflammation. And then lastly, bigger patients and males. If you have a fat male sitting in front of you and you're going to start a monoclonal antibody, you should have a low threshold to be thinking about needing more drug right off the bat. So these are the high-risk patients. So think about that person sitting in front of you. The person with an albumin of 2.8 who's got an obese BMI, who's a male, who's got bad colitis and an elevated CRP, you know up front that if you're going to use your drug, you better be on your game, and you're going to probably need to use combo therapy or use higher doses when you start. So this is how you can think about trying to approach the primary non-response. The pitfalls of primary non-response is if you give up too early on an agent that might work. We don't want to do that. But more often, people leave patients languishing on therapies for weeks, months. It goes on and on and on, and it's often the steroids. It's also not often that we're getting into surgery when we should be. If they come to you with an obstruction, they're going to need a surgery at some point in their life unless we can somehow manage this aggressively up front. And if that's the inevitable consequence, don't keep escalating medical therapies when a laparoscopic resection with an enhanced early recovery is going to be a much better way to get them where they need to go. And I already talked to you about dosing and the fact that despite we're getting better at therapeutic drug monitoring, there's a lot more to do. Now, another pearl for you about primary non-response is when you look at vedolizumab, which is the top of this slide, and ustekinumab, which is our newer agent, at the bottom of the slide, the message is clear that in patients who have already failed anti-TNF, for whatever reason, intolerance or non-response or loss of response, they are less likely to respond to the next mechanism. They are less likely to respond to vedo or to ustekinumab. So the message is choose the right therapy up front, use it appropriately early, and you're going to have a greater likelihood of response. So it gets back to Mark's talk, which is when should we be thinking about using vedo as a first-line therapy, or when would we use ustekinumab as first-line therapy? And also when we communicate with patients and payers, the discussion about why we want to use one drug over another and how important it is to get our patients where we need them to be. The other concept that's emerged has been using treat to target. How do we use the treat to target strategy to help guide us? Well, it gets back to this objective measures of disease activity. So the general concept of treat to target is you choose a target, usually it's related to the inflammation, whether it's CRP or fecal calprotectin, but occasionally in an individual patient it might be growth, it might be improvement of their hemoglobin, and you adjust their therapies in a sequential, predefined way until you get to where you need to be. So you assess the target, you adjust your treatment, after a defined period you assess the target again, and you keep going until you hit your target. The reason I bring this up in our primary non-response part of the presentation is really just to drive home the point that when you start someone on a therapy, you should always be telling them how long before they should start feeling better, and you should always have a plan for when you're going to reassess to make sure they're on the right track. And just saying, let me know how you do, is of course not the way to do this any longer. And for most of our therapies, telling them they're going to feel better within a few weeks, and we want them to be in remission by 3 months is reasonable. One of the most significant papers that's been presented was presented at DDW, and you'll hear much more about this, was a study called CALM, which was a prospective treat-to-target study. And Jodfred Colombel, on behalf of many investigators, presented this. It was 10 years in the making. And basically, this was for newly diagnosed Crohn's patients who were randomized to either conventional symptom-based management, which is what most of us do in our practices, or a treat-to-target strategy that used both CRP and fecal calprotectin, stool markers, to guide choices of therapy. And the algorithm essentially said that for patients who qualify, you'd start with adalimumab at standard loading and maintenance dosing. You would be escalated to weekly adalimumab, and then you would be adding azathioprine to the management. That was the treat-to-target step-up algorithm in this strategy. And the conventional management was whatever the doctor wanted to do, essentially. And what they found was that the patients who were being managed based on their CRP and their Calpro were much more likely to achieve mucosal healing, which is seen on the right there. And, very interestingly, and we'll be seeing more of this, they're less likely to be hospitalized, they're less likely to have surgery, the things that you would expect. And this makes sense. This is almost like deja vu because we were expecting it, we're talking about it, but this is the first prospective evidence of treat to target in IBD that actually demonstrates such great response. And so whether you looked at any of the sub-points and secondary endpoints of this very important trial, it was a key message. So in your primary therapy for a patient, when you start them on treatment, make sure you know when you're going to check to see if they're responding, not just symptom-wise, not just from the quality of life point of view, which is of course important in what I started with, but also with these objective measures. Okay, and then a shorter part, which is really important because we have other speakers that are going to address some of this, is what do you do with the patient losing response? Well, first of all, how do you assess these patients? Everyone who's on a biological therapy who comes to me in clinic, I ask them if they've been stable since I last saw them. And then I ask them if between doses of their biological therapy, are they stable? Because, of course, maintenance is about keeping them stable, not about them knowing when they need more drug. I have a patient who used to say that she was hungry for her infliximab. Of course, she used the brand name, but you get the idea. We don't want patients to feel hungry for their drug. Maintenance is about keeping them completely well. So when you see them in the office, you are assessing, are they taking their medicine, and are they stable and feeling as well as you expect over time? And now we've increasingly been using other ways to prove that. So it's not sufficient to have the patient say, yeah, I've been great, and then to find out their CRP is elevated when you do your routine labs. You need to think carefully about how to address that. So why do patients lose response? Infection. Of course, Clostridium difficile is epidemic. Changing in the dose, maybe you stopped rectal therapy, or maybe you lowered the dose of a medicine because you felt like you could. Maybe the physiology of the disease has changed, as I've mentioned to you. Maybe the patient has decided that they just don't want to take their medicine. That happens a lot when they're feeling well, and who's to blame them? Maybe we've decided that they don't need some of their therapies and stop them on therapy, stop their therapies. And unfortunately, more and more, we're worried about patients who can't afford their medicines, who have delays when they go to reauthorize their therapies. And one of the biggest challenges I think about biosimilars is not whether they're similar, but rather whether we're going to get patients to stay on their schedules as they get switched from one drug to another, depending on which agent is the cheapest this week. I'll talk about that later. Now, it's also common that patients lose response. This is from the 3 pivotal trials of maintenance of anti-TNF. You can see across all 3 survival curves that after the patients responded, half of them across all these agents lose response by the end of a year. So this is a common problem. We've learned, however, that if you use the drugs earlier, it's less likely to happen. So this is an administrative claims data assessment that we did a few years ago, looking at a very large database. And we looked at everyone who was eventually treated with anti-TNF. And if they were treated with the anti-TNF within months of their diagnosis, they were less likely to lose response over time. They were less likely to need surgery. Now, my hypothesis was actually the opposite. I thought that anyone who was getting treated with anti-TNF that earlier in their treatment course must be really sick, and I thought that they were going to actually do worse. So I was actually wrong. And we don't know about disease activity when you do claims data analyses. But the message was earlier use of the therapies, less loss of response. So again, this old strategy where we're waiting for people to get sicker and fail their therapies and then finally need their biologics is wrong. You've heard Mark tell us about risks for progression. We know the patients who are at highest risk. We should be using effective therapies earlier and get them where they need to go because they're going to have better outcomes short-term and longer-term. Who is at risk for anti-drug antibodies? Well, Adam is going to teach us a little bit more about that. But of course, it's not just the patient getting episodic therapy. It's also the patient who bottoms out their drug levels in between dosing, what we call pseudo-episodic therapy. And finally, if you have a patient who's developed anti-drug antibodies previously, they've already told you that they're an antibody former. When you give them their next antibody-based therapy, make sure you're taking precautions to prevent the anti-drug antibodies. And then we're going to have an entire lecture on therapeutic drug monitoring. So I have one slide just to tell you how this is evolving. It's evolving in the use for assessment of loss of response, of course, the assessment of post-loading, knowing who's going to lose response so we can predict it, the assessment of the patient who's in stable maintenance phase when we're considering de-escalation, after a patient's had a drug holiday and when we're considering restarting the drug, and to avoid combination therapy. You saw that in Mark's presentation. I'm guessing that Adam will touch on it as well. So there are lots of ways now that we're starting to appreciate how we can measure drug levels and use them to help our patients more effectively. And we'll be getting into some of that during our panel discussion as well. So I'll end with this, the approach to the patient losing response. First of all, take a careful history. Is this a pattern of attenuation, meaning that they describe to you over time, I was losing response, then I'd feel better when I got the drug, then I felt worse again, or did this just happen right away? They fell off a cliff. Rule out infection, C. diff, C. diff, C. diff, but other things too. Confirm active inflammation. Make sure you're treating the right problem. Very commonly a challenge here. And then find out where your drug went. Is the patient taking their therapy? Is the drug getting where they need to be and at the dose you need? And have they developed an antibody response to the therapy? So the approach to this, and this is going to be in your slides, of course, for you to all look at, is to have an algorithm where after you've ruled out infection, after you've confirmed active inflammation, in a patient who's lost response to anti-TNF, but frankly, this is going to be something we can apply to our other antibodies, figure out what's going on with your drug. I often say that therapeutic drug monitoring is most useful when there's no drug detected, when it's zero. And a lot of the other stuff is gray, and hopefully Adam will help clarify some of that for us. But if there's no drug detected and there's no antibodies to drug, try to increase the dose, decrease the interval, push it. If there's high drug level and no antibodies, this is where you would consider swapping, that's the term, to another class of therapy. This is when you move on to our other treatments and some of our novel strategies. And the harder part is when there's low drug or undetectable drug with some antibodies, but you think they're low titer. Now, this is an evolving definition, but the general concept is, can you treat through antibodies in some patients, and can you overcome them? And there's some literature to suggest that if drug is present with antibodies, those antibodies may not be actually neutralizing. You can still use your therapy, increase the dose, maybe add an immunomodulator, and see if you can get through it. And I know Adam's going to talk more about that. So think carefully about where the drug is and what's going on with your patient before you make any treatments. So I've covered quite a bit here, but hopefully I've given you a practical approach to the management of IBD, both when you're starting therapies and they're not necessarily working the way you wanted them to, but also, of course, after you've used the therapies and if patients are starting to lose response, which is the natural tendency of chronic conditions. Thank you very much for your attention.